Good morning, ladies and gentlemen. I think we will make a start. For those of us who are here now, we have a very exciting session for you. My name is Ben Challicum, and I'm co-chairing the session with my friend Tom Walton. I'm very grateful to Joe Creswell and BAUS Oncology for the opportunity to put this session together and to have what we think will be an exciting hour for you. Just some admin side of things. I would like you to turn your phones on, but your noise off, and start getting the app up, because the app will be very useful for our debate. And you can also send questions to us on the iPad through that app. And if you want to, you can also tweet us some questions with the hashtag BAUS17. So I'd like to ask Tom if he would introduce our first speakers.
Welcome, everybody, to what promises to be a very stimulating debate on a hot topic. I'd first like to introduce a counter debate on the question: prostate biopsy is not required for PIRADS 1 and 2 lesions. So, in speaking for is Caroline Moore. Caroline needs no introduction. She's a reader at University College London and an honorary consultant urologist, and spent many years in MRI for clinically significant disease, MRI targeted biopsy and active surveillance, and also focal therapy. Against is Paul Cathcart, friend of mine, ex-Melbourne fellow, consultant urologist at Guy's Hospital. He has an extremely large radical prostatectomy practice. He's also the PI for a number of studies, including the RAF study, PRIME study, and also the PROVENT study. So without further ado, I'd like to introduce and invite Caroline up to the stage, and we'll take it from there.
So can we have the voting slides up, please?
Great. So thank you very much for the kind introduction and this opportunity. We wanted to start with simple vote. There's 2 questions now. So if you could turn to your apps and vote yes, no, or sometimes for whether or not you use MRI before first prostate biopsy. I think that will, if I click it, that gives you your time. There we go. So 81% there, very encouraging for a starting point. And then we have our second question. And for our second question, we can move to that on the screen, please. Brilliant. So this is the matter of the debate in hand. Would you recommend prostate biopsy for a man with a low-risk MRI, classified as PIRADS 1 or 2? Okay, great. So a real spread of responses there, which is exactly what we want to see at the beginning. Thank you very much. So I shall now argue the case that prostate biopsy is not required for PIRADS 1 and 2 cases. So I think, first of all, you need to just take a moment and think, why do we do biopsies? Why do we want to find cancer? Well, we've very much moved from wanting to find any cancer to wanting to find clinically significant disease. And if you ask 100 urologists what clinically significant disease is, you may well get 100 or at least 50 different answers. And the truth of the matter, as we all know in daily practice, is that it depends on the age, comorbidity and preferences of the patient. So we all agree that Gleason 9 in a 40-year-old is significant, a couple of millimetres of 3+3 in a 90-year-old is not significant, and there's a range of opinions in between. And to my mind, what we need to be doing is reviewing the MRI scan with the patient and having this discussion. We look at the guidance that we've got to hand. So the 2014 guidance includes prostate MRI. There is a recommendation to do an MRI for a man with a negative biopsy and not to offer a biopsy if the MRI is negative. So here's a signal that we should be taking on board the MRI result and using it to allow us not to do a biopsy, in this instance, in the negative transrectal biopsy population. We know that we all need to do an MRI for a man with a proven cancer, and NICE is the very first guidance in the world to say that during active surveillance, we can choose an MRI or a repeat biopsy as a surveillance tool. What NICE didn't address was the first biopsy. Should we do an MRI before first biopsy? And one of the reasons is that we've been waiting for this landmark study, the PROMISE study. So PROMISE enrolled 740 men across a number of UK centres. 576 men had all the tests, and the tests were 1.5 Tesla MRI, a general anaesthetic under which the man had a 5mm transperineal map, so not a targeted biopsy, but a 5mm transperineal map, and a 12-core truss. So that for once we could actually compare standard biopsy versus 5mm template versus MRI. So when we look at the results of PROMISE, we can look at the sensitivity for detection. You can see here the flowchart showing that all 576 men had all 3 tests. And just a word about the primary outcome. So the primary outcome is what we call definition 1 disease, which is essentially what you see in red here. So it is 6mm of any cancer. That can include Gleason 6 or any primary Gleason 4+3. The secondary outcome was definition 2, and that's the yellow block, 4mm of any cancer or Gleason 3+4. And you can see here that when we look at definition 1, the sensitivity of MRI for detecting primary 4+3 or 6mm of cancer is 93%. Trust biopsy is 48%, a clear winner for MRI there. We also know, as we said at the beginning, that we define clinically significant disease differently in different circumstances. And another very reasonable definition is any Gleason 7. When we look at the sensitivity of MRI versus truss, MRI is still winning, 88% versus 48%. However, the question I've been tasked with today is if the MRI is negative, do we need to do a biopsy? And the negative predictive value exactly addresses this. So the values for definition 1, 89% versus 74% negative predictive value, and for Gleason 7 disease, 76% versus 63%. So less of a distinction between the 2 tests there. When we do a standard truss, we know that we detect significant cancer, and most of that cancer we would have detected on template. We also know that when we do a standard truss, we tell a significant number of men that they have no cancer. And in fact, here you can see the block, 119 men who were told on standard biopsy would have been told you have no cancer, had a significant cancer. We need to break it down further. The question put to me was PIRADS 1 or 2, low risk MRI. So you can see from this, the green is no cancer, it's stratified by its MRI score. The orange is insignificant cancer, which is essentially 3mm of Gleason 3+3 or less. And I would argue that's insignificant in everybody. And you can see our proportions there. So there is a small proportion of men who have significant disease with a PIRADS 1 or 2, but it is small. And when we look more closely at those missed cancers on MRI, we see that if we look at definition 1, 17 cancers were missed, and 16 out of 576 men were Gleason 3+4 disease of an amount that we would see as significant. That works out at 2.9%. However, doing trust biopsy, we miss 119 cancers. So again, MR works better than trust biopsy. So if we say, well, it is unacceptable to miss that 2.9% of Gleason 3+4, significant disease, or the 6% of Gleason 7, then we need to work out what we're going to offer. The best way to absolutely know for sure whether or not you have prostate cancer is to have the whole thing taken out, step sectioned every 2mm, and have a pathologist spend a year looking at it. However, it's not great as a diagnostic test, and it would never be acceptable. So if we look at the potential harms of a 5mm transperineal map, which is what you need to do to pick up the cancer that you're going to miss if you don't biopsy your PIRADS 1 or 2. This is the picture study, a study where we did a transperineal map, 5mm sampling, plus a targeted biopsy in men who'd had a repeat biopsy. 249 men. But there was significant morbidity here. 45% of men reported a reduced urinary flow, 23% urinary retention rate, perineal skin infections, and erectile dysfunction, 20% for a diagnostic test. To my mind, unacceptable. as a standard diagnostic test. So I would put to you that we need to do the maths. Yes, we will miss a few cancers. 2.9% of definition 1 cancers, 6.9% Gleason 7 disease. But the alternative is the 5mm template biopsy, and that has significant risks. So I would suggest that we don't let the perfect be the enemy of the good, and I look forward to hearing Paul's comments on it.
Thank you very much, Caroline. And first of all, I'd say congratulations on the Blandy Prize. Fantastic, fantastic. So I have the potentially unenviable task of recommending biopsy for all patients with PIRAD 1 and 2. Unenviable because a few years ago it would have been the enviable side of the argument. Things have changed a little bit. So I'd like to start with prostate cancer screening. Prostate cancer screening is controversial due to overdetection. Why is there overdetection? Sorry. There's overdetection. The screening study over the time has demonstrated the benefit of screening increases with the longer follow-up you have. But still, public health doctors don't want to recommend it because of the potential harms of overtreatment. MRI, exposing men to a second screening test, potentially enables smarter screening. And if you're going to get smarter screening, it's probably by not biopsying PIRADs 1 and 2. The European randomized group have done a further analysis where they've incorporated MRI in the screening process, exposing men to PSA testing followed by imaging. And they've developed a risk calculator which reduces, if you incorporate MRI, 65% of patients won't need to undergo a biopsy. You don't detect low-risk disease in 68% of patients, and you have an equal detection of high-risk cancer. So MRI seems to be very effective in reducing overdetection on a population level. But we're interested in a patient-level data, really, because that's the person who's coming to see us in the clinic. This guy, it's not his picture, but I actually saw this guy yesterday, and he's a 52-year-old guy with an MRI scan which demonstrates a small prostate, 20 cc, and he wants to know, what should he do? He's on an individual patient level. This is not population data that we want to know. And so if we go to the PROMISE study, which Caroline has very eloquently discussed, what we're interested in here, I don't think I've got a pointer, but the first bit of the figure shows MRI significant. They think there's cancer on the left. They don't think there's cancer on the right. 17 patients had significant cancer if the MRI didn't think you had cancer. So by my reckoning, and I'm not a maths expert, 10% had significant prostate cancer with a PIRAD 1 or a PIRAD 2. The majority were PIRAD 2. So if we look at the outcome, the primary outcome of that study is any primary pattern 4 or a maximum cancer core length of 6 millimeters or more. That is an extremely liberal criteria for clinically significant cancer. It excludes all patients with a Gleason 7 up to 5 millimeters. You could have extensive Gleason 7, 10 out of 10 cores, which we do see sometimes, but the cancer core length is less than 6 millimeters. Those patients are regarded as insignificant cancer. So what is significant cancer? Well, I would argue we should look at our active surveillance cohort. Laurie Klotz is famous, and rightly so, for having a very large and a very well-documented patient group in patients with active surveillance. Hot off the press from December last year, he has advocated that we don't monitor Gleason 7 anymore. If you look at 15-year metastasis-free survival for Gleason 7, this is favorable Gleason 7, 3+4, the metastasis-free survival rate goes from 94% to 84%. So any pattern 3+4, any pattern 4 seems to impact on metastasis-free survival, and they don't recommend it. So that's a very much less liberal group that we're looking at. So if we look a little bit deeper into the table, the first bit, as we've seen before, is the primary definition. Secondary definition is where you have 3+4 up to 4 millimeters. The negative predictive value is suddenly dropping greatly from 89% to 72%. So MRI is not performing particularly well in patients with low volume 3+4. This graph you've seen before, PIRAD1, about 5% with the primary definition had significant cancer. Up to 40% had either 3+3 or 3+4. That's with PIRAD1. 10% PIRAD2, up to 40% have some 3+4 with them 3+3. These are relatively high percentages. So here's my chap again. He's got a 10% risk of primary pattern 4 or maximum cancer core length of 6 millimeters, and up to 40% of any cancer. He's beginning to get a little bit worried. The next thing is inter-observer variation, and this is from the PROMISE study as well. And it looks at agreement between 2 different radiologists or multiple different radiologists. And the first thing to say is the radiologists were all on the same page when it came to PROMISE. They had extremely good training. They were selected because they were good radiology groups. But that isn't what we're getting in our day-to-day practice. 2 papers, one from New York, one from NIH, and they've looked at inter-observer variation for different radiologists. The first study from New York, they had something called a K statistic, which looks at the level of agreement. And basically, they came out with a value of 0.34. This is moderate at best agreement between 2 radiologists. The NIH group was a little bit better, but there's huge variation depending on which sequence you're looking at. If you go down to T2 weighted, the K statistic is 0.11. There is huge variability in what different radiologists are saying are cancer or not. Now, I'm a surgeon, I take out prostates. A patient comes to me, he knows my length of stay, my margin rate, he can ask for my potency and continence rates. There's loads of data out there about me. If you take Dr. Smith, a hypothetical radiologist, how much data out there is there about him or her? There's nothing. Local data, local audit data is extremely important. What you really need to know is your radiologist a dedicated prostate radiologist? How many MRI scans do they do a year? What is their distribution of PIRAD scores? Because there's definitely something called a regression to the mean. So if radiologists become worried, they start calling everything a PIRAD 3. You should know the proportion of patients that they regard as 1, 2, 3, 4, and 5 on PIRAD scoring. And you should ideally know your local cancer detection rate per PIRAD score. There's no point looking at PROMISE and applying those results to your radiology that you're getting in the clinic. So the next thing I would say, every time I do a biopsy, a prostatectomy, I consent the patient for the potential complications. And I would argue if you're not going to biopsy someone, you may even want to think about consenting them not to biopsy them. Tell them that you've got your audit data, just like I tell them I have my audit data for my radical prostatectomy, and tell them what's the chances of missing a significant cancer. And the other thing, if you're not going to expose the patient to a biopsy, you should at least think about exposing them to a further reflex test. And those would be something like a PHI or a PCA3. PHI is really interesting, and the Cambridge group has looked into this. And certainly, if you're not going to biopsy this chap with at least a 10% risk of clinically significant cancer, I would recommend that you do a reflex test. And the last thing is a hypothesis thing. And I just throw it in to make everyone think. But in other tumor types, such as cervical cancer, if you can see a lesion on an MRI, that predicts local metastasis. So if we're only going to diagnose and only biopsy patients with visible lesions, we're potentially diagnosing patients we can't cure. MRI may be a phenotype for poor prognosis, and those who don't have a lesion, maybe they're the ones we can cure if we diagnose them. I don't want to treat everybody, I don't want to diagnose everybody, but if we don't biopsy these patients, we can miss the significant cancer. If we know, if it's a bit of Ronald Rumsfeld, it's the known unknowns which is the issue. So, my guy, he had a biopsy yesterday, and I still don't know the pathology, but we'll see how things go. Thank you.
So Paul has kindly allowed me the chance for a rebuttal. My first rebuttal, which has no sliders, the metastatic nodal disease, that was cervical cancer. We're in the urology conference and we're talking about prostates. That was cervical. However, Paul does have a number of good points. Not all MRI is the same, and we know this. In the UK, the UK guidelines say 1.5T is good, a 3 Tesla is better. You don't need an endorectal coil. Dynamic contrast is good if you can get it, and there'll be further discussion about that nationally. 79% of radiologists in the UK report doing an MRI before biopsy, but not all of them are using dynamic contrast. And there's a best practice statement in development from PCUK. There's already a UK best practice statement developed for NHS practice in the UK by UK radiologists. One of the important things is that you have a diagram reporting of your MRI scan and that you report all areas with a score. Paul's right, PROMISE was it was NHS scanners, ordinary scanners, but there was a lot of dedicated radiology training and work to get standardised reporting, and that's really important. The other question, we all sit with a man with a PIRADS 1 or 2, and he has some factors that don't fit. Paul's man had a PSA of 5 and a 20 mil prostate. And I would urge you to use all of your tools and not to go doing expensive things like PHI and PCA3, but simply to look at your PSA density. You've got your MRI, you've got a good estimate of the prostate volume from that MRI, and you know the PSA. Divide the PSA by the volume and you get your PSA density. It's really extremely helpful. So when we look at this group, 280 men, and they use the same clinical definitions as promised, but they divided the scores, 1, 2, 3, 4, and 5, and stratified men by PSA density. If you have a PIRADS score of 1 or 2, and a PSA density, or 3, a PSA density of less than 0.15, they found no cancer. I think that's a really good safety net. So if you do have your 1 or 2, you can biopsy the man with the higher PSA density. Very helpful data there. The other question is whether we can do a targeted biopsy alone or you need a systematic truss in addition. And the answer is we need precision. So naturally, we have another trial, randomizing men to targeted biopsy alone, no biopsy if the MRI is negative, or a standard truss. This is a collaborative effort. We have 25 centres across Europe, Canada, and the UK. And we've had the most fantastic recruitment to this collaborative study. We've recruited in 18 months what we said we would take 2.5, and the results should be available in the autumn. Last slide. We believe that a urologist should be able to read a prostate MRI scan in the same way that many urologists read their own CT scans for stone. Plug for our course in September at UCL, which will be addressing this exact point. And I think we have the further question, don't we, on the voting pads?
We do. Thank you very much to both speakers for a very thoughtful discussion. We've got time for very quick questions. So are there any from the floor? Joe, do you want to?
Can we have the app back up, the voting app as well, please?
So speaking just as a general urologist who doesn't know a lot about prostate cancer, know a bit about bladder. So PIRADS 1 or 2, okay, I might not need to biopsy, I decide not to do that. Then what do I do? Discharge forever? Or what?
So PIRADS 1 or 2 with a favourable PSA density, I think you can discharge to your GP and set a PSA at which the PSA density would become unfavourable. So depends slightly on age, but ask the GP to re-refer them when the PSA gets to the threshold where their density would be 0.15. That's my practice, which I think gives a certain safety net.
But that we're moving into completely unevidence-based practice there. There's absolutely no evidence for that. So I think, obviously, you don't, the MRI, if you've got a very large prostate, it's game, set, and match. You're not going to biopsy that guy. His life expectancy is extremely important. An old chap with limited life expectancy, you don't want to biopsy that person. But in a younger guy with maybe a rising PSA, our cancer waiting system doesn't allow us to monitor them anymore. You've got to make a decision. The other thing I would add is if you're going to do a biopsy, I wouldn't do a truss. PROMISE tells us truss is not very good. So if you're going to expose him to a biopsy, do a proper biopsy up front, and that would be a perineal mapping biopsy.
Very good, thank you. I think we're going to have to move on in the interest of time.
So can we just see the results of question 2 and then the results of question 3, which is the same question at the end? So if we got question 2 and then question 3 to see, it's not a competition, but to see who's won. No? So we've gone from 45 to 41 on the nose. Oh, 36 to 41.
Okay.
And that's well done, Caroline. Right, and now for something completely different. I'd like to introduce our next speaker, who is Professor Trinity Bevilacqua from Johns Hopkins. He's a member of a very rare group for me, which is people that I've seen lecture and also skied with. And because he was very kindly came on one of our RSM trips earlier this year, and we were all got on so well, and we thought perhaps Trinity could come and address one of the key issues, I think, in world and particularly British urology, which is about really how we're going to take on urothelial bladder cancer, how we're going to make a difference in what has always been quite a underfunded Cinderella disease. I've just retweeted something saying that the average amount of money raised in this country for breast cancer is £1,400 per patient. For bladder cancer, it's £20 per patient, and that gives you some idea of really the level of the lack of investment and funding and research in this area. So Trinity's going to tell us over the next 20 minutes really how we might put some of the new biomarkers into use in this area. Trinity, thank you.
Well, actually, Ben and Joe, I really appreciate you guys allowing me to come here and talk. And actually, it's an honor to be in a prostate session. It's very unusual for a bladder guy to give the stage with prostate. But nonetheless, I'll talk and do my best to tell you about what we know about biomarkers to predict chemo responsiveness in patients with muscle-invasive disease. This is my disclosures, nothing relevant to today's topic. This is sort of the way that we manage early stage disease, locally advanced or muscle invasive disease, as well as metastatic disease. And this is sort of, if you look on every guidelines, this is kind of what it is. What I'm going to talk about today is clearly the role of neoadjuvant chemotherapy and how we can best choose that patient to give chemo prior to a cystectomy. Well, we know that this works. We've got level 1 evidence from a number of randomized trials which have showed a clear survival benefit. And this has been brought into guidelines in each of the Canadian, the EAU, the AUA, NICE, that you've got clear evidence and they recommend neoadjuvant chemo. But this is sort of, as a urologist, this is the problem. And when I say the problem, it is hard to get a lot of urologists to refer their patients to the medical oncologist to get cisplatin-based chemo because of this curve. This is just data from Hopkins, but we can take this from the SWOG trial. We can take it from any retrospective analysis. And the top curve are the patients that received neoadjuvant chemotherapy, gemcitabine, and cisplatin with a clear survival benefit. Look at that, 80 to 85% of patients at 10 years are alive and well and disease-free. But if you receive chemo, which is the bottom, and you do not respond, so you have great T2 or greater or lymph node positive disease, look at that curve. It's clearly these patients are not doing well. And if you don't receive chemo, look at that curve. You see that they actually do better than those patients that receive chemo. So non-responders to systemic chemotherapy have a poor prognosis. So what are the potential harms? And once again, as a urologist, this is what you're asking. Direct effects of chemotherapy, hearing loss from cisplatin, neuropathy, acute kidney injury. We all see this. There is increased DVT, PE rates with cisplatin-based therapy. You have a delay to cystectomy, and in those patients that are non-responders, that could clearly impact. And there's a small portion of patients that never really get to cystectomy. And there's always the thought, well, could I have done this earlier and therefore help this patient? So the evidence clearly shows that there is a survival benefit. However, 40% of patients will receive a major response, and therefore, as a urologist, you're thinking, well, 60% don't, so how am I going to choose this? So therefore, it hasn't taken on in the United States as well as Europe. In the United States, only approximately 30% of patients that have muscle-invasive disease that are eligible for cisplatin receive chemo. I don't know the numbers in Europe, but that's actually up over the last 2 years. So the solution is simply this. Could we identify patients that are going to be responsive to chemo? And this is where we get into tissue biomarkers. So this is sort of ways that we could predict molecularly patients that are chemo responsive. There's a number of both trials as well as a number of extensive research that's being put into this, looking at molecular subtyping, tissue biomarkers, genomic alterations, circulating free DNA, and then the Coxin model, which is a randomized trial that's being conducted in the United States. I'm going to talk to you about the first 3 topics and see if I can put this in a way that is going to make sense for the practicing urologist. So the first question is, what is the clinical impact of molecular subtyping, and can this biology of the primary tumor help us choose appropriate treatment? So if you heard my talk yesterday, we had a lot of discussion about the molecular genomics of urothelial cancer. This is sort of a summary of the TCGA, the discoveries by MD Anderson and David McConkey, Billy Kim at UNC, as well as the Loom Group. And what this shows is that we can subtype tumors into basal and luminal subtypes. There's also P53-like, we've got Claudin-low, we've got a number of different classifiers. And this has been, this is very analogous to breast cancer. So when we think about breast cancer, how do we treat breast cancer? Well, this is actually an algorithm for how breast cancer oncologists are recommending treatment. You can see very clearly that using immunohistochemical staining, you're able to subtype the tumor. Is it a luminal A? Is it a luminal B? Is it a HER2 positive? Is it triple negative? And depending on what this staining shows will depend on if this patient received endocrine-based therapies, hormonal therapy, cytotoxics, and the like. So this is already being done in breast cancer. And as I just told you, urothelial cancer and breast cancer show very similar molecular genomics. So this is actually the first report in 2014 for Woo Yun Chung and David McConkey, who I'm very fortunate to have. David McConkey, we actually lured him away from MD Anderson and is now at Johns Hopkins. So I have a lot of access to the ability to understand genomics from Woo Young and David. And what they showed in this first study in cancer cell was that if you had a molecular subtype of P53-like, this is, I had a gene expression profile which had P53 based upregulation, not necessarily mutation, but gene pathway, that you were unlikely to respond to chemo. So if you look in that middle bar, the yellow are non-responders. So you had only a few patients that actually responded. So if we look at this sort of in a Kaplan-Meier curve, as I pointed out earlier, if you have a patient with a basal subtype and did not receive chemo, their outcome on that bottom panel is clearly worse than patients that had luminal or P53-like. But if you gave them cisplatin-based chemotherapy, you can see that things flip. These patients were more responsive to chemo and actually were able to show a survival benefit, as you can see on the basal. And once again, the P53-like are just our bad players. So this is an example of how molecular subtyping could predict chemo responsiveness. And if you, once again, I always go back to the breast cancer literature, and I know this is hard to see in this bottom, but if you look at the basal-like subtype, this is a complete response to cisplatin-based chemotherapy. 73% of patients will have a response. Whereas if you look at the Claudin-low and the luminal, you have a lot less response. Once again, very indicative of what we see in bladder cancer. But really, as the urologist is sitting in the audience, well, what does this mean? These guys are they're completely doing RNA-seq, they're doing these very fancy bioinformatics to predict subtyping. What can I do? Well, this is actually Roland and Peter Black just published this in European Urology. It's a multi-institutional, where they're actually using the Genome DX platform. This is an Affy array in which they are able to use tissue that's sent to an outside company, and they're actually able to give you subtyping of tumors using their platform. So this is commercially available. the consensus subtyping for this was broken down into basal, luminal. Is it infiltrated, non-infiltrated? And why does that matter? Because that's actually important for T cell activation, which we're going to come to next, which is where we could predict potentially a response to immunotherapy. And in their study, they saw the exact same thing as MD Anderson, which is the basal subtype, once again, in that red bar, going down. If you did not receive chemo, had poor prognosis, but as soon as you gave those patients systemic cisplatin-based chemotherapy, they had an overall better survival. So once again, highlighting how molecular subtyping could work. But really, I go back to us. So which subtyping system do we adapt? I just showed you multiple different ways to subtype the tumors. Luminals do well regardless of neoadjuvant chemo. Well, maybe these are the patients that just go right to cystectomy. Basal subtypes do poorly without chemo, but do extremely well with chemo. There are 4 different class systems. Which one do we use in our clinical practice? And there's the UNC classification actually performed the best out of the 4. So these are questions that we need to address in randomized controlled trials. So this brings me to our next tissue biomarker, which is the PD-L1. We're all aware of immunotherapy and its effect in metastatic disease. So as I told you, subtyping tumors, you can subtype them into tumors that are infiltrated with T cells. So infiltration of T cells would suggest that this is a immune charge, is sort of the best way to think about it. So we know from the Invigor and tislelizumab that if you had PD-L1 staining greater than 5%, you actually had a better response. And if you look at that trial, they actually subtyped the tumors and were able to show that luminal infiltrated tumors, which is that second bar, the responders, they had a lot more patients with metastatic urothelial cancer that responded to a checkpoint blockade. So this is another example of how subtyping and understanding the biology may predict response to PD-L1. So that brings us to the tumor microenvironment. So the microenvironment is important as it relates to understanding urothelial biology. Here, I show you a study where we could actually look at T cells, CD8, CD4, FOXP3. These are activated T cells that are important for a balance between effective and regulatory T cells that are going to help either suppress tumor or actually allow tumors to grow. Going back to breast cancer, melanoma, if you have tumors that have more FOXP3, these regulatory T cells that are actually bad, think of them as a bad player, you actually are less responsive to systemic chemotherapy. And this is just an example in breast cancer. So the question is, can we use that as a way to predict response to cisplatin-based chemotherapy in urothelial cancer? And does the PD-L1 and PD-1 pathway actually, is it plausible to also predict response? So in order to do this, we developed a TMA. A TMA is a tissue microarray where we took TURBT samples prior to cisplatin chemotherapy, and we're able to look at a number of markers, PD-L1, TILs, tumor-infiltrating lymphocytes, as well as tumor expression. We also looked at a number of TILs, CD8, FOXP3, to understand the biology. What we found is that the difference between responders and non-responders to chemo, there was no difference in PD-L1 staining. What that would suggest is, and also makes sense biologically, that wouldn't necessarily predict response to chemo. And that's something that's important because you as a urologist, a medical oncologist, you want to have something in your back pocket. So these are the patients that you actually know may also respond to a systemic checkpoint blockade. Moving on to sort of the next finding is that if you stratified CD8 and FOXP3 by PD-L1 staining, that did not predict response. But what it did show is an adaptive immune resistance in these patients that are tumors that were not responsive to chemo. So what that means is that as a tumor prior to cystectomy, if you've got more FOXP3 expression than our CD8, this tumor is already been upregulated to actually evade therapy. So why is that important? Because if that's the case, then can we stratify by CD8 to FOXP3 ratios? Long story short, that if you have more CD8 positive cells to FOXP3 cells, those patients had more of a complete response. So Why does that matter? Because as we move forward, we can look at the immune microenvironment as well as molecular subtyping to help predict response. And I think for time, I'll just say shortly that genomic alterations, which are mutations in the tumor, may also predict response. Bladder cancer is a heavily mutated tumor, unlike prostate and kidney. So these are the tumors that may respond the best to systemic immune checkpoint blockade or potentially cisplatin-based chemo. Jonathan Rosenberg at Memorial Sloan Kettering published this paper a couple of years ago where he looked at DNA mismatch repair gene mutations, ERCC2, and showed that if you had this mutation up here in the top, that you actually were going to predict response to cisplatin-based chemo. So this bar up here showed that responders had a higher mutational load, and if you had ERCC2 gene mutation, 9 out of 25 complete responders, once again looking at cystectomy, PT0, actually had this mutation. This was validated at Fox Chase and showed that a panel of DNA mismatch repair gene mutations also predict response. So actually, in the United States, there's trials where you are performing sequencing to look at somatic mutations, and they're randomizing patients to cystectomy versus no cystectomy. So as a urologist, I actually have a problem with this, because when we look inside of a bladder to endoscopically stage a patient prior to cystectomy, we oftentimes will see nothing. We take out their bladder, and all of a sudden we've got disease. Could be CIS, could be a small papillary tumor, could be muscle-invasive disease. So right now, there are trials that are saying a cysto in the office with a mutation in ERCC2 is a predictive of response, and therefore you don't need your bladder out. So when I saw this a couple of years ago, we developed a protocol at Hopkins where I bring every single patient to the operating room prior to cystectomy, and I TUR their tumor base, and I resect all visible disease. And then I do their cystectomy a week later. Why did I do this? Because I wanted to ask the question, can we properly stage our patients prior to cystectomy to do more bladder preservation? And actually what we found, and this is the take-home point, that clinical T0, which is that top, is what we saw in patients that were clinical T0, which is what I saw endoscopically. 26 of them at cystectomy were T0. But look at the numbers here. If you look at those patients that were T2, T3, T4, there was actually over half of patients, or approximately half of patients, still had invasive disease, despite a mucosa and a bladder that was visibly clear. So my concern is that we, as urologists and scientists, are trying to advance the field, but we have to be smart about it. So actually, I would argue that we need something like this. We need to be able to molecularly subtype the tumor, understand the tumor microenvironment immunologically, and also look at somatic mutations, and then as well as our staging clinically, to then be able to predict patients that have responded and therefore choose the most appropriate therapy. So I'll end there and acknowledge my team, and we can take questions later. Thank you.
Trinity, that's absolutely fantastic. I really felt like I understood the way you took us through that, and that, of course, is the master of a clinician scientist to do that for all of us urologists. It really shows that individualized treatment in this area is going to be the way ahead. My question is, a cash-strapped NHS, where we are every year falling behind what we should be doing, what is the first step to get the maximum bang for our buck here in terms of where should we be pointing the individualized medicine first?
Yeah, great question, and I will tell you, in the United States, we need to actually do the same, right? Because we're cash strapped. And what I think we need to do is what the breast cancer surgeons and scientists have done, which is we do all the science, and we are fortunate to maybe get funding from foundations, from our government, to do the science, and then develop very standardized immunohistochemical tests to be able to understand sort of what's going on at a molecular level. When we can develop those tests immunohistochemically, that any pathologist can do that costs literally less than $1 for the antibody and the charge slide, then we can then potentially go to this risk-adjusted molecularly based approach. Until then, it's not going to happen. It's also not going to happen in the United States. So we've committed at Hopkins with our institute to actually do that, to sequence every tumor that comes into the door, every patient that comes to see me, that I remove their tumor or comes from the outside. We're isolating RNA and DNA, doing this, and then we're also working with our pathologists to correlate that with immunohistochemical stains. That's the only way it's going to happen.
Time for one more question. Anything there? I mean,
I have one, Trinity. When we get pathology reports back that say we have a micropapillary variant or a nested variant, how do the results hold for those patients?
Yeah, so what I didn't show you there was our understanding of for example, micropapillary variant is actually a luminal subtype of, and for example, a squamous basal. What we're finding is that they fit into the subtypes, and that they're also predictive, just like the original. So I think it actually, in my opinion, when you see a variant histology, getting the understanding of molecular genomics actually will help you predict what you're going to do. So it's still a big clinical question that we all struggle with. What do we do with this patient? Great, thank you.
Right now, it gives me great pleasure to introduce Declan Murphy to the stand. He is a mentor of mine and a friend, and he needs no introduction. He'll get one anyway. So he is Associate Professor and Director of GU Oncology at the Peter MacCallum Cancer Institute in Melbourne. It's the largest cancer centre in the Southern Hemisphere and has recently had a $1.1 billion overhaul. And Declan's going to talk about oligometastatic cancer. So Declan, welcome.
Thank you, Tom and Ben. And yeah, it gives me a great pleasure to deliver this talk. The background to this discussion is work we've done at Peter MacCallum Cancer Centre, and both these guys did fellowships with us in Melbourne with Tony Costello and myself, as did Paul Cathcart. So we're very proud of our Melbourne alumni who are doing such a great job here in the UK. So let's start with a very familiar tale to those of you working in prostate cancer. A patient has very much like the opening debate, somewhat raised PSA, has an MRI, as everybody in Australia does actually, visible lesion, and goes on and has radical prostatectomy, PT3A, grade group 2, negative margins. And the PSA becomes undetectable, but the PSA starts to rise. The patient has salvage radiotherapy when his PSA is around 0.2. The PSA goes down. Isn't this all familiar? And then the PSA goes up again, of course. And for what it's worth, he's very anxious now, of course, so he has a CT and a bone scan, which are always normal, useless investigations in this low PSA setting. And that's the question is, what do you do now? What do you do with these patients? And these are not rare. This is, up to 1/3 of radical prostatectomies over a 5-year period will have biochemical recurrence, and they will have typically nothing visible on imaging. But they're very anxious. We know they've got cancer somewhere. They know they've got cancer somewhere. What do we do with them? And I suppose that's where this whole discussion about oligometastatic disease has become an area of a lot of interest in the past few years. We know these patients will have disease outside the prostate. And that's the premise. If we can identify that disease, and if it is truly low volume, and we ablate all that disease with stereotactic radiation or a salvage lymph node dissection, could we perhaps go on and cure some of these patients, or at least defer the requirement for systemic therapy? But the big limitation in this enthusiasm we have for oligometastatic disease is the fact that the very term oligometastatic is a function of imaging sensitivity. If your imaging is very sensitive, then yes, you may truly be counting low volume disease. But if your imaging is very inaccurate, as CT and bone scan will be in this setting, then you will have a poor outcome if you're pursuing an ablative strategy in those patients. So fast forward to the interest that we've all seen in recent years in PET imaging for evaluating this type of patient. And I point you towards this very useful review article in Nature Reviews Urology from some of our German colleagues, summarizing the role of PSMA PET imaging in particular in prostate cancer. And they summarize it with a few key points here, pointing out that PSMA PET adds molecular information to whatever other spatial information we get on these patients. We have increased specificity and sensitivity compared to conventional imaging. And even at very low PSA levels, like this index patient I show you, we can pick up these small metastatic lesions in a way in which we never did before. And here's an example. This is a patient who was enrolled in one of our oligometastatic protocols in the pre-PET imaging era, where they had to have 5 or less metastases and they would be eligible for stereotactic radiation. But this is the same patient's PET scan at enrollment. And we modified this study to allow for exclusion in patients who had a sodium fluoride PET or nowadays a PSMA PET to reveal the true extent of disease. Because what's the point in ablating these 4 lesions here when there's an overwhelming amount of disease outside the prostate that will clearly make no meaningful difference to the patient? So I'll just show you a few brief slides about PSMA. I'm sure you've all heard a lot about it in the past few years. And this is from the original paper from the Heidelberg group who developed the current flavor of the month ligand, gallium-68. PSMA11, and this was their comparison with choline PET, and what you see here is choline PET images on the left and the same patient having PSMA images on the right, and you see much more obvious presence of these lesions, most of which were biopsied in this small series. And also for bone disease, the choline scan is on top, and you get a lot of background noise with choline in the bones. And what you see in the bottom image is the PSMA PET average bone metastases, which you can't see on the choline image. So PSMA PET has rapidly replaced choline in most big centers doing prostate cancer imaging for this type of reason. And the same group 2 years ago reported their initial experience of biochemical recurrence, so very much like the index patient I've shown you at the start. And what they show here as you move from left to right is rising PSA levels. So we have a PSA of less than 0.2 on the left, for example, when about 20% of patients, even at this very low level, will have a positive PET scan. And as the PSA rises up in the biochemical recurrence setting, again, we see improved accuracy of PSMA PET in this cohort. We presented 600 patients of ours at the EAU this year with a very similar spread. On the left, you see PSA less than 0.2. We only had 16% of patients positive in that setting. But when you get to a PSA level of 0.5 or thereabouts, about 50% of our patients will have identifiable lesions. We've biopsied lots of these. We know that the specificity is extremely high, approaching 98%. But the sensitivity really depends on the PSA level that you're at. What we also observed was that even at low PSA levels, and on the left is patients with a PSA of less than 0.5, you see an interesting distribution of these lesions. And in clinical practice in Melbourne, in our multidisciplinary team meetings, this is what we see. Not just lesions down in the pelvis, but lesions in the ribs, left supraclavicular region, etc. So patients who, in other words, would be suitable for salvage radiotherapy, not infrequently have disease well outside the pelvis. And as the PSA rises, the next image is PSA up to 2, and PSA is higher, we see a really quite wide distribution of lesions. And that's one of the attractions of a one-shot scan that will show you lymph node disease, visceral disease, bone disease, local recurrence, is you get that all in one shot, in one scan. Interesting distributions. We published a meta-analysis recently in European Urology of PSMA PET imaging, looking at about 1,800 patient reports in 17 articles. And yes, we showed very high specificity, but sensitivity really depending on your PSA levels, as we summarize here in this table and in this graph. So obviously we need to try and think, what's the cut point? At what level should we do a PSMA PET scan in a patient with biochemical recurrence? If you start very low, you're going to have a lot of negative scans. If you leave it too late, you'll probably have more distant disease. And I think that's an area of ongoing exploration. So regarding these recurrent settings, I think PSMA PET is probably the one that will help us define oligometastatic disease in a more accurate fashion. And what we'll speak about now, though, is, well, what do we do with that oligometastatic disease? We certainly need better comparisons with conventional imaging, and we have a prospective randomized control trial already recruiting in Melbourne for the primary setting, and we do need better correlation with tissue. We've just recently written in BJUI about something I was speaking to Trinity about earlier, the fact that this has become a test for the general public in countries like Australia and Germany, because the scan has become widely available. So we've written that it's almost like a plague running out across Australia, the availability of PSMA PET imaging, and that's not always a good thing, I can tell you. For example, back in October 2014, when we were the first centre providing PSMA PET scanning, it cost about $900 for a scan, and we were getting up to 12 requests a day, so there was a 3-month wait all of a sudden for a PSMA PET scan. Fast forward to today, and there are 14 different providers in Melbourne alone, a city of about 4.5 million people. The price has dropped to about $500, and you can pretty much get a scan the same day. So what that means is people are coming in the door with PET scans all the time, primary, grade group 1, grade group 2, PSA 0.07. Yes, they're coming in with a PET scan in the community. So it's a real challenge. This is not necessarily a good thing because we don't know what to do with all these scans. And it's almost like the way we've seen an increased number of publications on the topic of oligometastatic prostate cancer, and this is if you do a PubMed search over the past few years, a sudden boom in interest in oligometastatic disease. And I'll come back to that in a moment, but I'll digress for a minute if you'll indulge me, Chairman, and remind us of another big craze we saw exactly 1 year ago when Pokemon Go was launched. And I'm sure if I went around the audience, I'd still find that app lurking in some of your phones. And you remember this craze when it got launched last year. The whole world went crazy going around the place trying to find these little Pokemon. It broke all sorts of internet records for downloads and activity. I see there were like 90 billion Pokemon were caught in 5 months. And these are the sort of little creatures that you were looking for in your phone, wandering around different centers trying to find these rare Pokemon, and these are the sort of scenes we saw 12 months ago as people were congregating in parks and around other areas trying to catch these Pokemon and build up their collection. And this is a scene from Central Park in August last year when about 2 a.m. when an extremely rare Vaporeon was spotted in Central Park, and people are abandoning their cars in the middle of the street trying to catch these. It was a really hilarious craze. So we've just written in European Urology, reflecting on Pokemania, if you like, and the way the world went crazy for that. Got to catch them all. That was the catchcry for Pokemon. And reflect a little bit about this craze we've seen for oligometastatic disease. And I think what we note is that as we try and catch this collection of little critters here for your Pokemon app in your phone, you can parlay that with a sort of Pokemet. We've coined this phrase. When we see these little metastases, particularly on a PET scan, and patients see them, they look at the images and see this little colorful creature, and yes, of course, they're going to want stereotactic radiation or a salvage node dissection. You're not really going to leave it in there, doctor, are you? And this is the sort of image you see. The little Pokemets are popping up here, there, and everywhere, and this is what we've seen in Melbourne, because we've had a few protocols open for stereotactic radiation. You ablate the first one, another one pops up, another one pops up, more radiation, another one pops up back down here. And it's really challenging to understand, is this a reasonable strategy? Is it a meaningful thing to sort of ablate these things, granted in a low morbidity fashion, or should we have a totally different approach? And what we've seen is, as we've had a huge growth in publications on PET imaging, PSMA PET imaging. This is the graph for oligometastatic disease on the right and PET imaging on the left. And I think this, in Melbourne, certainly the PSMA PET craze is driving the oligometastatic craze, and it's quite a challenge in our daily clinical practice. I showed an example of one of my patients in this European Urology paper who has a small obturator node recurrence, and then he had stereotactic radiation for that on a protocol. It disappeared, but his PSA is still rising, you can see. And then another one pops up, and then 2 more pop up. Pre-sacral PSA is rising. Patient's anxiety is rising. Radiation oncologists are still treating it. And I think we've stepped back a little bit from our enthusiasm for this type of approach. And when we identify this oligometastatic disease, I think what I've described to you have been our more recent paradigms: stereotactic radiation in a protocol, of course, ideally; salvage lymph node dissection. What's the role of that if you have 2 or 3 PET-avid lesions? Or should we really be thinking about managing this as a systemic disease? The little signals we see on the PET imaging is never the full extent. That's what we now see. There's always more when you go and do a node dissection or whatever. But here's a typical example: a patient who's had radiotherapy, radical prostatectomy followed by radiotherapy, PSA 1.2, and we see common iliac and external iliac nodes. The patient has stereotactic radiation, the PSA goes down. Does that really matter? The patient is happy for a moment, but then the PSA we've now seen after a few years of this is always rising again in these settings. And there is some data on this. I'll just show you this particular paper from Pete Ost, who's a very good radiation oncologist from Ghent. And what they show here is that this is well tolerated even in the repeat setting. These are patients who've had repeat stereotactic radiotherapy. But look at these progression-free survival curves. These patients will almost inevitably go on and have further clinical recurrence. And defining the meaningful endpoint might be our biggest challenge here. Is it a meaningful endpoint that the PSA goes from 1.2 to 0.4, or that they avoid ADT? I'm not sure. Defining meaningful endpoints is one of the most important challenges here. Here's a patient with a PSA of 0.1 post-op, T3 disease, perfect candidate for salvage radiotherapy. Would you do any imaging? Well, he was enrolled in one of our prospective studies for patients being considered for salvage radiotherapy, and there you see he's got lots of retroperitoneal nodes. So if he had had salvage radiotherapy, we know it will make very little difference to his clinical recurrence-free survival. And perhaps that is a role for PET imaging here in better selecting patients for salvage radiotherapy. And pelvic lymph node dissection, we've had some interest in our group. One of my colleagues, Phil Dundee, has been doing quite a few of these cases. And what's the role of salvage lymph node dissection in this group? Well, this is in the choline era, a well-cited paper from Francesco Montorsi, and they show, first of all, reasonable morbidity in this. This is a significant undertaking, an extended salvage pelvic lymph node dissection. And unfortunately, again, we see very similar patterns of clinical recurrence as we've seen in the radiation series. So I would say we need to think about what the guidelines remind us about, and that's that this type of approach, this POCAMET approach, as we've made fun of, is experimental. And it's not that we shouldn't be doing it, but we should be doing it in prospective studies to see does it make a difference. There are a number of prospective studies open around the world, including the trombone study here in the UK, but that's based on conventional imaging. That's defining oligometastatic disease on really quite inaccurate, useless investigations. And I think we should be embracing the newer technologies in clinical trials to define this cohort of patients. So this may be just a spectrum. Of course, it might be truly stable, low-volume disease, or it might be on the way to quite disseminated disease. And I think that this type of ablative approach is therefore experimental. I think finally, PSMA PET imaging, which we have a lot of experience of in Melbourne, is a big leap forward, but we still need to better define its role. Which are the appropriate patients, and how should we manage the decision impact of seeing these lesions on scans? And I think the POCAMET approach, got to catch them all. It may be successful for some patients. Some patients, I think, will benefit when we've seen that in our practice. And Tony Costello, who's here at this meeting, has a large number of patients with these recurrences over a 15-year period. And certainly we've seen in our multidisciplinary meetings with Tony that some of these patients will do well. But many won't. They'll just go on and have repeated therapies. And I think we need to better define the oligometastatic population who will benefit. Finally, can I plug 2 meetings that we're running in Australia over the next 6 months? Many of you have been to Tony Costello's Prostate Cancer Congress, which takes place at the end of August every year. We have a fantastic faculty lined up again, all household names. Chalicum's coming again this year. And it is really a very intense few days of prostate cancer down in Melbourne. You're all very welcome any year. We run every year. And finally, USANS, our annual scientific meeting, it takes place in February next year in Melbourne. That's summertime, and myself and Daniel Moon are convening that meeting. Tim O'Brien's among the guests for next year, so I encourage you to put these in your diary and plan a trip to Melbourne. Thank you very much, Ben.
Thank you, Declan. That was truly excellent. Do we have any questions from the floor? We've probably got slightly over, but we've got time for one question.
Could you just do the question with the mic?
I think I know the question. Yeah, it's a great question. So most of the data is on biochemical recurrence, but your question is, would we do these scans in a patient before radical prostatectomy, and would we be put off a radical if we find? So this is a really important, challenging issue, because patients are coming in the door with intermediate risk disease and a PET scan in their hands with an avid lesion somewhere. And sometimes it's not just an external iliac node. It'll be a retrocrural node or a left supraclavicular node or an uncertain rib lesion. Ribs are one of the areas where we do get false positives, actually. So to answer that question, we have a $1.5 million prospective randomized control trial currently recruiting for patients with high risk or high intermediate risk cancer. So that's grade group 3 or above. We opened in April. We've already recruited 40 patients into this 200-patient study. And they're randomized to have conventional imaging and PSMA imaging. So they cross over. They get one or other first. And we record the decision at each point. So the point is to record, does your decision change based on what you see on the imaging? So the study doesn't mandate what you do with that patient with an unusual, more distal thing, but it'll be interesting for us to record, is it affecting clinicians' decisions? But we will get the accuracy data comparing conventional imaging with PET imaging, and we will get a lot of tissue, because almost all these patients will have a radical prostatectomy, many of whom will have a node dissection. And it's a weekly challenge for us in Melbourne is patients coming in saying, I was lined up for surgery and now I've got a scan with a funny thing, and I've been told maybe I shouldn't have surgery or radiotherapy. And our view on that is this is an experimental scan, and we shouldn't clearly throw the baby out with the bathwater because of this new scan and deny a fit 58-year-old person radical treatment. We've been treating these patients for years with positive scans, only we didn't know about it. And it almost opens up a different question, the role of primary treatment in patients with metastatic disease. And I think we know that lots of patients with high-risk disease will have metastases, and it doesn't mean they won't benefit from primary control. So the answer is prospective trials are answering this question for us.
Well, Declan and all of our speakers, I think we've just gone 5 minutes over. We'll call it there. We're very lucky to have such esteemed faculty. I hope you've all enjoyed this, and I wish you well for the rest of the meeting. Thank you.